go into the next topic today. I think so. For the people who have attended top classes regularly, we had this covered during the regular respiratory session classes. But prone ventilation can come in as both your systemic paper as well as some ethics can be asked in your basic sciences as well, and this can come even in your practical. So there is no actual delineation for such topics. So that's one of the reasons we took this topic as well. Firstly, I would like to convey my condolences to Gattinoni. I think so. You all know that he passed away in the previous week, and he was one of the doyens in critical care who have actually strived a lot in the field of both fluid management and mechanical ventilation. And he was one of the people who also had a lot of trials on prone ventilation in ARDS. So the outline of the present talk would be under basics and introduction. Physiology is the main thing that I'm focusing, but I'll also be looking into indications, contraindications, and evidences as we go on. So the main focus is physiology. The question has been asked previously in the 2018 DM paper, wherein they have asked about evidence for ventilating a patient in prone for improving oxygenation. This can be asked in any other ways as well. So physiology, if they ask, probably like how they ask about west zones, etc., they can ask about prone ventilation as well. So we all know that it is one of the only evidence-based technique that has shown some mortality benefit in patients with ARDS. It has shown to improve lung compliances along with ventilation perfusion matching. Usually because we are recruiting the posterior atelectatic lung, which is usually left without better ventilation with perfusion being intact. So that is one of the important physiological considerations that showed better outcomes with patients being prone with ARDS. We all know that heart and the anterior lung fields are placed down, and instead of acting with gravity in prone position, the contrary happens, because of which the recruitment helps in better VQ matching. Okay, so the mismatch is lost. There have been a lot of trials showing that inadvertent increasing of PEEP, etc., has caused a lot of VQ mismatch. In certain cases, also has led to barotrauma. Those things can be, averted if we actually do proning at the earliest. So, looking at a person with a normal lung, so leave alone a patient with ARDS. We'll take a patient with normal lungs. So this is what usually the lungs and the anatomy looks like, right? In a supine position, the heart is placed anteriorly. Majority of the lung, which is aeratable, is present in the posterior part. Correct. Usually, the gravitational force by the anterior mediastinum falls onto the recruitable part of the posterior part of the lung, which probably offsets the ventilation perfusion, leading to a poor oxygenation in the long run. Similarly, we see that the same effect can happen as well in the abdominal contents. If you take liver as well, this A here stands for anterior and posterior. Liver as well puts a major, a gravitational force on the posterior part of the lung, which decreases its recruitability, thereby worsening the VQ matching. Okay, so that has been offset in a prone ventilation. As you can see, this part of the lung is better aeratable. The whole thing about proning is about knowing the recruitability of the posterior part of the lung along with certain other hemodynamic changes. Okay, so the other most important part along with the gravitational force that we need to know is about the elastic recoil of the lung and the chest wall. Okay, the chest wall usually is more rigid. If you see the third image here, the posterior part, which usually comprises of the rib cage as well as the vertebra, is said to be very rigid. That is, the distensibility of this part of the thoracic cage is very poor. So when you're ventilating this patient in a supine position, the most this gas exchange that can happen is mostly anteriorly, because the anterior part of the chest is more compliant. Okay, and that can help in better gas exchange. But unfortunately, what happens is a pendulum phenomenon, wherein the alveoli which are already distant will get more ventilation as compared to the ones which have been collapsed. So that is one of the other things which have been offset by prone ventilation, wherein if you put the patient in prone position, the better compliant part of the chest wall, that is the chest wall, which can come into the recruitment, or it can expand as we do ventilation, that is placed in the prone position, and that is in a dependent position, that can still expand and better recruit more alveoli. Okay, so by this, what happens is there will be a homogenized ventilation that can be set in. The whole part of this would be, to help recruit more and more alveoli, which in turn, with the presence of better perfusion, will improve oxygenation. So coming again, we need to know firstly, it's the gravitational changes that we need to consider. Okay, that is the anterior mediastinum having its effect on the posterior part of the lung. Then the abdominal contents similarly having the compression effect on the posterior part of the lung. And then the chest wall mechanics that we need to consider. That is, the anterior part of the chest wall is more compliant, which can help in better gas exchange and movement when it is placed in a prone position. So I hope you are with me till now. So coming to the core concept of today's class, that is physiology. How does it help in gas exchange? How does it help in carbon dioxide clearance? What is the improved lung mechanics that we see? What are the better, hemodynamics, or what are the hemodynamic considerations that we need to have in prone position? So a question can come as, what are the physiological consequences of prone ventilation? So you might have to answer them under these headings. Okay. So firstly, gas exchange is what we need to consider. We all know gas exchange is usually both oxygenation as well as carbon dioxide clearance. So oxygenation, quite clear. We have already mentioned about dorsal recruitment and preservation of perfusion. I'll be talking about preservation of perfusion when I speak to you about hemodynamics. Okay, coming to the concept of carbon dioxide clearance. So when you have carbon dioxide clearance, you can consider two scenarios where the carbon dioxide clearance is present, wherein it leads to decreased alveolar improved alveolar ventilation, and the CO2 level will be released. That is, it is decreased. Whereas if you see that there is no carbon dioxide clearance, it can be as similar to which is seen in the supine position, or in fact, sometimes it can be more than that. Okay. So sometimes what can happen is, if the patient has a lot of secretions, or if there is a dense consolidation which is being present in prone position, the carbon dioxide can get retained and it can cause hypercarbia. Okay, so this is what we see. So in case there is better recruitment, there is better alveolar ventilation, the CO2 level will decrease. So how does that happen? Both oxygenation and carbon dioxide clearance will happen when there has been recruitment, better ventilation, and that leads to better CO2 clearance. Okay, so this is about the concept of gas exchange in prone ventilation. Okay, remember about oxygenation, remember about carbon dioxide clearance, also mention about perfusion. Okay, so coming to lung mechanics. Lung mechanics, the most important thing that we need to know under these three headings, that is homogenization of the transpulmonary pressure, thorax and the lung shape mismatch, and the lung mass distribution. Okay, I think so. Thorax, lung shape, and the lung mass distribution you might have understood in the initial slide, which I showed about the effect of the anterior mediastinum as well as the thoracic cage. So we are speaking about transpulmonary pressure. So what do we mean by transpulmonary pressure? It is nothing but the alveolar pressure minus the pleural pressure, the difference which causes the air to enter into the alveoli. That is what is important. So consider the particular scenario. You have a patient who has an isolated lung. Okay, so this is outside the rib cage. Okay, the triangle. So when you have an isolated lung which is being studied in supine position, you see there is homogenization of the alveoli. The red color here refers to the perfusion. The blue circles here refer to the uh, alveoli. Okay, so in an isolated lung, the effect of gravity on the alveoli is very less. Okay, but there comes a position when you have the thoracic cage here. Okay, so when the thoracic cage is acting on the pulmonary anatomy, that is the alveoli, you see that is there is a mismatch, or else there is a disparity in the oxygenation or the alveolar distension. As you can see, the anterior alveoli are better distensible as compared to the posterior alveoli, which is under the effect of gravity. Okay, so there will be some amount of shape mismatching. Along with this, we also have to understand the concept of perfusion. Here, blue refers to less amount of circulation. As it becomes more red, it is better perfusion. So this is something that you need to understand by this legend which is present in the corner here. Okay. So as we all know, when there is better perfusion in the posterior part of the lung as compared to anterior part of the lung. So what happens in prone position? So we all know in supine position, there is inhomogeneity in the alveoli which is present. Okay. And the effect of gravity causes increased VQ mismatch. Okay. If this is understood till here, we'll go to prone positioning. The first and most important thing that we need to know about is the blood flow remains the same. It doesn't get changed. That is, the local perfusion remains intact despite it being anterior or posterior. Okay, even in prone position, the better perfusion is seen in the posterior part of the lung, that is more recruited in the prone position. What surprisingly happens here is something called as shape matching. As you can see, as the time progresses, you have better shape matching which sets in, and it is almost like a homogenized picture, which is similar to that of an isolated lung. So this is one of the most important things that happens in prone positioning. Because of homogenization and shape matching, there will be easier ventilation because the transpulmonary pressure or the pressure required for ventilation would come down. Okay. So coming to the next two things, that is the thorax lung shape mismatch and the lung mass distribution. As I've already told you earlier, the effect of the lung uh, because of the abdominal contents like the liver or the anterior mediastinum structures like the heart falling onto the posterior part of the lung would be offset in prone position, wherein better compliance is achieved. The most important thing here you need to remember is about the anterior part of the thoracic cage, which is more distensible, because of which the posterior part of the lung gets better aerated. Similarly, the anterior part of the lung also gets, uh, you know, uh, better aerated, not like the posterior part of the lung. What happens previously here is this is a rigid structure here, correct, in the supine position. Because of the rigidity, also the expansion of the alveoli would be lost. But what happens in prone position? Because the anterior part of the chest wall is compliant, this rigidity is lost, and better distension of the alveoli can happen, wherein it decreases the ventilation perfusion mismatch. Is it clear? Okay. So in general, this is what you need to understand. There is imbalance between shape matching gravity and the superimposed pressure, which usually happens in supine position, which is offset in prone position. Okay. The most important thing is the shape matching, which happens, because of which there's better recruitability and better oxygenation, which is seen in prone position. Coming to the last part of this physiology of prone ventilation, that is hemodynamics, we all must remember the first and foremost thing is there is no change in the regional circulation. That is, the posterior part of the lung, which is more recruitable in prone ventilation, is better perfused even on pronation. Okay, there will be better perfusion in the posterior part even in supine position. Okay. Coming to the systemic circulation, what usually happens in systemic circulation is, because when you prone the patient, there will be a shift from the splanchnic circulation. When you change the position, there will be increased pulmonary artery occlusion pressure, and there will be decrease in the physiological dead space, which converts the West Zone 2 to West Zone 3. We'll be discussing about West Zones in later sessions today, so you'll be able to understand. What usually this part you need to understand is uh, the alveolar pressure is more than the venous pressure. Okay, so this helps in better oxygenation, which actually sets in and changes the West Zone 2 to West Zone 3. Okay, and because of this, there will be increased CO2 clearance. Okay, decreased hypoxic pulmonary ventilation, as mentioned earlier in the session, and because of which there will be homogenization of the ventilation perfusion. Okay, so remember, there will be increased circulation into the systemic part, especially towards the lungs, because of which the conversion of West Zone 2 to West Zone 3 will be present, because of which there will be better ventilation that happens, that actually increases the CO2 clearance. And because of homogenization of the ventilation and perfusion, it leads to increase in ventilation and perfusion. That is, the mismatch is lost. Okay. So this was actually studied by Gattinoni way earlier. Okay, probably this was one of the earlier monographs that had come in. Okay, and 20 years later, he actually published another study. This is in 2021, quite recently, and this gave us an evidence beyond any doubt. Okay, understanding all the physiology. That time, probably it was just a theory, probably just a hypothesis. But over the span of the last 2 decades, all of this has been quite established. So, in summary, if any question is asked about physiology, in supine position, there is lower PaO2 to FiO2, elevated presence of partial pressure of carbon dioxide, low lung compliance, and heterogeneous lung aeration. But prone, what happens is there will be better, you know, ventilation perfusion that increases the PaO2 by FiO2. That is, your Caricos index will be usually improving if the prone is effective. Lung compliance will be better, and there will be a larger amount of homogenized lung. Okay, so this is what has been established even after 20 years. So this is the reason probably Proseva was one of the earlier trials to give mortality benefits with patients with ARDS. So what they did in the Proseva trial was this: they looked into certain parameters in supine position and prone position. Okay, so they checked the thing both in supine position itself, but the second part which you see here is after 18 hours of proning. So the PF ratio before proning was roughly around 74. The carbon dioxide was around 54. The plateau pressures was around 27, and driving pressures was 21. Okay, so this, if you look at this picture, after 18 hours of proning in the Proseva trial, what they looked at was there was significantly improved oxygenation, okay, thereby also reducing the plateau and the driving pressure. So this is something that was achievable by prone ventilation, and probably this combined effect had the mortality benefit which was seen. So indications when and in whom to initiate prone ventilation. I know you guys cannot unmute, so that's the reason I'm just going to make it a little fast. Okay, so the indications for prone ventilation, we all know. Whenever there is a PF ratio of less than 150, probably you might have to think about proning the patient. 16 hours of proning is usually recommended, and it can be increased up to 24 hours, but you also need to know there will be a lot of nursing issues, or there will be a lot of other pressure related issues that can happen for prolonged proning. Okay, one thing that we need to understand is uh, whenever this patient is planned for proning, always make sure that you oxygenate the patient with 100% oxygen, and then you can start titrating based on the response. Okay, so in the Proseva trial, what criteria they used is if the PaO2 FiO2 ratio is less than 150 millimeters of mercury, especially after 4 hours of supinating, with PEEP and FiO2 cutoff of 10 centimeters and 60% respectively, they probably thought that the prone position can be discontinued. Okay, so this is one of the cutoffs that we thought for discontinuing prone, but the by and large criteria for initiation is the PF ratio less than 150. Okay, so uh, longer hours can be considered only if you have adequate people to help you monitor these patients on prone ventilation. Okay, so there will be a lot of checklists that needs to be considered. Okay, this is something away from physiology. Always remember there are things that you need to consider before proning, at the time of proning, and after you finish, you need to have a certain checklist to avoid any unnecessary events that can happen during proning. Okay, so always remember that you need to have a lot of members that is required. So the staffing is the key indicator here. Okay, so always make sure the pressure points are padded. Oral care, probably if you require lines, that has to be taken into consideration. NG feed just prior to proning can be discontinued, but there is no contraindication for feeding in prone position. Make sure that the patient is having adequate sedation. Use a RASC score to keep that in check. Okay, so always make sure there is no inadvertent compression of the abdomen, and especially the eyes and the cheeks. These are prone to have some pressure source. Okay, some amount of reverse Trendelenburg position has shown to have a better ventilation perfusion matching. Okay. Nursing care, you need to remember always, the pressure points have to be padded perfectly. So you can use one of these checklists that have been, given. Most of the NHS hospitals do have this. Okay. So you can use this for the bedside checklist so that you can prevent any inadvertent issues that can happen during proning. Okay. So always remember, the person who is starting the prone has to mark in a few things. That is the time of proning, what are the ventilatory parameters prior to proning. Okay, this can help the person coming after you to understand whether there is an improvement in oxygenation or not. Also keep and check about the ventilatory parameters like the driving pressure, plateau pressure, etc. Okay, so that can help in understanding whether prone was beneficial or it wasn't. Okay. What are the contraindications? Broadly, it is divided into two. That is absolute contraindications and relative contraindications. The absolute ones are unstable spine fracture, open chest. Okay, uh, ECMO. Mostly, if you have people around, you can still do prone ECMO. But yeah, if you have a central cannula, if that is occluding, then probably it might not be a good idea to do proning. Relative ones are hemodynamic instability, abdominal wounds, long bone fractures, okay, morbid obesity, late-term pregnancy, recent tracheostomy for the only issue that it might get dislodged, and it would be catastrophic if the patient's airway is lost in prone position. Raised ICP or anything associated with brain, like a recent trauma with a large traumatic brain injury, is also a relative contraindication. But always remember, in prone position, if there's a head low position, which is usually offset by the reversed Trendelenburg, there is a risk of raised ICP that can be seen. Most of the times, I think so. People who have been doing proning quite often will see, right? We usually have a swollen face, swollen eyes, if not looked into all of this. Okay, so these are the contraindications for proning. As I've told you, ECMO, there have been a lot of evidence. Recent 90-day, mortality has been established by meta-analysis by Coombs et al. Only thing is there needs to be a perfusionist always round the clock present. Like in any case of ECMO, probably you need more staffing. These are the things that we need to consider, but there has been definite indications of better outcomes with ECMO and proning, which are done together. Okay. How do you check for improvement? What is the cutoff? Usually, what they say is any 20% improvement in oxygenation should be a good enough indicator for established better outcomes or a successful prone ventilation. That other thing that you can use is a tool like oxygenation index. If you see that the patient's oxygen index is more than 20, probably it indicates a severe oxygenation index, or that is, this patient might worsen and might need a ECMO. So if it's more than 25, consider ECMO in such cases. If the oxygenation index has reduced by roughly around 20% after proning, it gives you an idea that this patient can be prone successively. Unfortunately, ProSeva or subsequent trials do not give the number of attempts that you need to prone. If the first attempt at proning has failed, can we do the next proning quite early? Or how many sessions of pronings are required? These questions are a little clinical oriented, probably has to be taken in a case to case scenario, and then can help us understand better. Awake proning, we have all seen the effects of awake proning in the recent pandemic of COVID. This is one of the protocols that have been used, that is the SPANK protocol. Whenever the PF ratio is more than 200, if the patient is on a high flow nasal oxygen, use the ROX index. If the ROX index is showing better outcomes, especially after a 3 to 8 hour period of prone intermittently in the day, you can continue doing prone ventilation for patients on HFNO as well. Whenever you see that the ROX index is less than 3.85, or the PF ratio is less than 200, or the saturation drops below 90%, as which is seen here, it indicates failure of self-proning. So these patients might have to be initiated on invasive mechanical ventilation, and thereby optimizing ventilator parameters on a supine position, and then probably, if that is also failing, can be considered for prone ventilation. Always remember, the SPANK protocol starts with uh, measurement of ROX index, okay, and then go with the measurement of the subsequent ROX index at 2, 4, and 6 hours. If it is showing an improvement, continue and encourage the patient to do proning. If not, then you need to consider invasive ventilation. Always remember in SPANG protocol, like in any case of severe hypoxia or moderate hypoxia, there will be no bathroom privileges. So the patients have to be cared at bedside. Coming to the evidence, this is just to complete because we have spoken a lot about this. There have been a lot of trials in ERDS prior to this. The earliest evidence for prone ventilation was in 1940s and 50s by Bryant. Okay. After that, in the 80s and 90s, there were multiple trials that was done. What they focused basically on was mortality benefits. But unfortunately, in 2001, the ARMA trial didn't still come in, and the tidal volume concept was not up to the mark. So they were still ventilating with 10, roughly here 10 to 13 ml per kg of tidal volumes. So that, along with the duration of prone ventilation being around 7 hours, did not give a mortality benefit. So that is one of the things or limitations, I would say, by the study by Gattinoni and Guerin himself in way back in 2001 and 2004. Here, I would like you guys to have a look at these two parameters. Okay, so the average tidal volume in both these studies, if you can see, is roughly around 12 to 13 ml, and the duration was also quite low. That is around 7 to 8 hours per day. So that is one of the reasons that probably they have not got any mortality benefit if you see in the earlier two trials. Okay, but this trial actually gave us the understanding that there can be mortality benefit with prone ventilation. What the major thing that we can see here is the tidal volume was reduced along with the stabilization criteria. Okay, so along with this, the duration of proning was also important. So here they used a tidal volume lesser than that done by their predecessors, that is Guerin and Gattinoni. Along with that, the duration of proning was roughly around 17 hours. So probably because of this, there was a significant improvement in mortality, that is 43% as compared to 58%. Okay. A similar things was seen in TACON, but what they saw was it was not significant at that particular time. But we all know the landmark trial, that is the PROSEVA done by Guerin in 2013. It was stopped intermittently, I mean, in between itself because it gave us a good result, correct? So here we see the best tidal volume they could take in was roughly around 6 to 7 ml per kg. They had a 17 hours of proning which was given. Okay, so this showed us great mortality benefit. The number needed to treat was very low as well. If I'm not wrong, probably roughly around 7 to 10 was the number needed to treat. So this is about the evidence in prone positioning. So recently, Munshi et al. Actually came in with another question. There were a lot of issues which we see, in the recent pandemic and prior to that as well. Whenever patients were prone, there were issues related to nursing, issues related to bed sores or pressure sores. Okay, so they wanted to look at to a condition wherein lesser number of hours would have a better effect, similar to seen in the PROSEVA trial. And they came with the conclusion that even 12 hours of proning would be sufficient for reducing the mortality rate in patients with severe ARDS. Thank you. This was another thing that we thought might be asked in your exams for people who have already attended this class in the top sessions. It's a revision like the prone ventilation again. Coming to the basic understanding of antimicrobial resistance. We all know there have been a lot of antibiotics that are present, which we are using day in and day out, right? So there will be drugs which are acting on the cell wall, cell membrane, or probably the protein synthesis like the 30S and the 50S subunit, or the nucleic acid pathways like the fluoroquinones acting on the DNA topoisomerase isomerase, so on and so forth. Probably 20, 30 years ago, this was not much of a nuisance, but currently in the scenario wherein the number of antibiotics available in the pipeline are going lower and lower and it's getting drier, we need to consider, the effects of antimicrobial resistance. So first thing, how can bacteria resist antibiotics? Mainly, there will be two ways that the bacteria resist the antibiotics. That can be the first way. It can prevent the antibiotic reaching its target site, like I've mentioned earlier, right? It can be the cell wall, the cell membrane, or the target sites, or the protein synthesis pathway. it can prevent the antibiotic from reaching the target site. Okay. The other way it can resist antibiotics is it can modify or bypass the target itself. Okay. So this is the two things majorly by which bacteria can resist an antibiotic. So when do we call an organism as a resistant strain? A bacterial isolate is considered as non-susceptible or antimicrobial agent to a particular antimicrobial agent when it does not meet the particular breakpoint which has been given to us by the UCAST or the CLSI. So there will be certain inhibitory concentrations and bactericidal concentrations which the UCAST would release quite frequently. Okay, the recent one being in 21-22, and in that, whatever is the cutoff which is mentioned, that if the bacteria is unable to be lysed at that particular concentration for that agent, then we call that agent as resistant to that particular bacteria. Okay, so I'll repeat myself. Whenever you have a particular bacteria which is not susceptible to an agent at a particular concentration as defined by clinical breakpoints given to us by UCAST or CLSI, then we call that organism as a resistant strain. Okay. So the susceptibility and resistance is usually measured as a function of the minimum inhibitory concentration. Okay, so the bactericidal concentration is something that we see wherein 99% of the bacteria should be lysed. So inhibition is usually the other function that we look into. Okay, so what you need to understand by minimum inhibitory concentration is it's the lowest concentration of an antimicrobial agent that inhibits the visible growth of the microorganism in vitro. Okay, it can be held. Usually, this is what is used to understand the susceptibility testing. Okay, so whenever you use your Malditov, etc., that takes into the MIC as the criteria to give you a susceptible, resistant, or an intermediate report. Okay, are you guys with me till here? Okay, so going on to the definitions of what are MDR, XDR, and PDR. MDR, also known as multi-drug resistant. It can be either a gram-positive or gram-negative bacteria, which is resistant to 3 or more antimicrobial classes. Like it can be cephalosporins, it can be carbapenems, it can be any other glycopeptides, etc. So one of these antibiotics or aminoglycosides, if it is 3 or more antibiotic classes the bacteria is resistant to, then they get classified as MDR. Okay, if what is extended resistant bacteria, wherein they will have susceptibility only to 1 or 2. Here you need to remember it is resistant to 3 or more. Here in extended resistance, it is susceptible to 1 or 2 categories only. Okay, so probably 1 or 2 drugs are only present for the action of these particular bacteria. What are pan drug resistance? These is something that most of us are facing quite often. So here, no agent tested would come as susceptible for that particular organism. Okay, MDR, 3 or more resistant microbial classes. XDR, susceptible to 1 or 2 categories or classes of drugs. Pan drug, no agent which has been tested is susceptible. Okay. Coming to the types of resistance. So we need to know there are 2 types majorly, that is natural and acquired. In natural type of resistance, it is innate or it can be mediated or induced. In acquired, it is defined by multiple ways like translation, conjugation, transposition, and mutation of chromosomal DNA. So what usually happens is natural is something that can be given to the daughter progeny of the bacteria by the mother bacteria. Okay, that can be innately given or it can be induced to the bacteria. This is usually by the vertical transmission. Acquired can be both vertical or horizontal, which can be by these methods, that is translation, conjugation, transposition, and mutation of the chromosomal DNA. Okay, we'll be discussing a little further as well on this. Okay, coming to the mechanism of antibiotic resistance, usually it is by drug uptake limitation, drug efflux. Okay, what do you mean by drug uptake limitation? Usually you give an antibiotic to a patient, okay, that has to act on the target site. If it has to act on the target site, say suppose it is the aminoglycosides, it has to go to the protein binding, that is the 30s ribosomes or the 50s subsegment. Okay, so if it has to go to that particular ribosomal unit, that can be broken down or it can be inhibited by the resistance pattern. So that is called as drug uptake limitation. Sometimes it can also be drug efflux. What happens is there will be efflux mechanisms that the bacteria would have taken in. What is the understanding of efflux? Just understand it like bacterial vomiting. Okay, the drug goes into the bacteria and the bacteria vomits out that particular drug. The drug was intended to kill the bacteria, but the bacteria outsmarted that and it starts throwing out that particular drug. What is the other way that it can develop? It is drug inactivation. The bacteria here outsmarts it again. The drug is taken in, okay, but it will develop some types of enzymes, or it would alter the target site or do other resistance patterns, and it inactivates that drug. So that is another type of antibiotic resistance that sets in. The last thing is the target site modification. It becomes oversmart in that position wherein the drug was supposed to act at a particular site, and that requires certain areas of matching, right? So, for example, if you take in a cell wall, you need a D-alanine type of a pathway for a particular type of a, say, suppose a cephalosporin or a penicillin to go and act on, right? Or the peptidoglycan layer. So that layer would get modified. Okay. So because that gets modified, the antibiotic just gets confused. It doesn't get a target site to act on, wherein the bacteria becomes immune to that particular antibiotic. Okay. So as the mechanism of antibiotic resistance clear, you have drug uptake limitation, drug efflux, drug inactivation, and target site modification. So this is what you need to write about mechanism of antibiotic resistance. Okay. So this is a pictorial depiction for whatever I have said earlier. Okay. So from the time it comes in, it can be blocked here itself. That is the decreased uptake. So say suppose there is a bacteria in which the drug outsmarts this and it gets inside. What happens? It can throw the drug out by vomiting. That is your efflux pump mechanism. Okay. So if at all this is come in and there is no active efflux, what can happen? There will be enzymes which can break this drug which is present here. Okay, that is the drug inactivation part. The last thing is the target site alteration. It can be either the genetic material which is present, or it can be anywhere in the cell wall or the cell membrane as well. Okay, I hope it's clear till now. Okay, the next thing is, what is the genetic basis of AMR? I told you earlier about mother and daughter cells, about horizontal transfer, about vertical transfer, so on and so forth, right? So before understanding that, we'll come on to understanding what are the genetic basis of antimicrobial resistance. You have two things which are important. One is the gene mutations. Other one is the acquisition of the foreign DNA via the horizontal gene transfer, or that is the HGT. Okay. So before understanding all of this, if you've understood whatever I've spoken to, just imagine that you have a bacteria, which is a very smart bacteria. It is probably of an MDR or a PDR variant, okay, or even XDR variant. It is a resistant bacteria. What are the mechanisms by which it can resist antibiotics? Firstly, by phenotypic resistance. That is the physical way, okay? That is the phenotype. It can develop some biofilms, etc. It can form something called as persisters, or it can cause something as swarming. Okay, these are the mechanisms by which it can phenotypically prevent the antibiotic from reaching a particular bacteria. Intrinsic resistome is what we are talking about in the present class, along with acquired resistance, which is mutations in gene transfer. Okay, so genetic basis, we spoke about chromosomal gene transfer. What usually happens is there are three different types of genes that we need to consider. That is for the target site of the antibiotic, genes encoding for the transporter of the antibiotic, or the regulator or the expression of efflux pumps, porin channels, etc. Okay, so it can be any genetic modification in the target site, transporter of antibiotic, or the regulator of expression molecules. That is the efflux pump or porin channels. Okay, this is the chromosomal gene mutations. What is about the horizontal gene transfer? That is the HGT. It is through the transfer or acquisition of foreign DNA through the transfer. That is usually a horizontal transfer between the bacteria of the same generation. Okay, that is another way of genetic basis of antimicrobial resistance. Okay, remember genetic basis, two things, chromosomal and horizontal gene transfer. And chromosomal, usually chromosomes have genes, right? So the genes can code for target site antibiotic mutations, transporter mutations, regulator mutations. Okay. Coming to gene mutations per se, that can be either intrinsic, acquired, or adaptive. Okay. So we all know there will be a lot of things that have been spoken quite in time in and time out, right? There are certain antibiotics are intrinsically resistant to certain organisms. So what do I mean by intrinsic resistance? It is the inherent natural capacity of a bacteria to show resistance to a certain class of antibiotics without having any mutations. Okay, it is inherently present for that bacteria. Okay, so what will happen is it will show inevitable resistance to a certain group of antibiotics. If at all there is an efflux pump or reduced permeability, which is usually involved for intrinsic mechanism, this is the pathway by which it can show intrinsic resistance. The meaning of what I said is the intrinsic resistance can be because of reduced permeability or efflux pump mechanisms. I hope it is clear. Okay. Sometimes multiple drugs can show intrinsic resistance to a particular bacteria, and that can be explained by multiple efflux pumps. For example, you can have an efflux pump for cephalosporins, you can have an efflux pump for carbapenems, or you can have efflux pump for aminoglycosides. So sometimes certain bacteria can have multiple intrinsic resistance patterns. I will be showing you a slide for which you can understand. Okay. So here you can see that anaerobes are resistant to having a resistance to aminoglycosides. Okay, here the mechanism is by uptake inhibition. Similarly, enterococci also have a resistance to aminoglycoside. Here, the problem here is oxidative mechanism is lacking in such places, wherein the uptake of aminoglycosides would be blocked by the enterococci. Okay. Similarly, you can think about gram-positive bacteria like probably streptococcus, etc., wherein the mechanism would be alteration of the penicillin binding protein, that is the target site for that particular type of bacteria. Vancomycin is usually resistant to gram negatives, wherein the inability of uptake itself is present. Okay, the vancomycin will not be taken into the gram negative bacteria. So that is the reason why gram negative bacteria are resistant to vancomycin. Okay. Similarly, metronidazole can be resistant to aerobic bacteria. Know that metronidazole is used for anaerobic bacteria, right? So why is it resistant to aerobic bacteria? It is because the ability to aerobically reduce the drug is lost in the aerobic bacteria. Okay, so usually there should be an anaerobic mechanism which is present. So that is not there in aerobes, right? So that is the reason why metronidazole becomes resistant to aerobic bacteria. Okay, I hope I have not confused you. Okay, just remember target site modifications would be there inherently present in that particular type of bacteria to a certain group of drugs. These are not something that they have acquired over time, or these are not genes that have been mutated. Okay, so we are talking about antimicrobial resistance, but this is something about natural resistance, that is the intrinsic resistance. Okay. Coming to acquired resistance. So till now we spoke about natural resistance. Coming to acquired resistance, we told about the acquisition of chromosomal gene mutation transfer that can happen by a horizontal gene transfer. Okay, that can happen in multiple ways like transformation, transposition, or conjugation. Sometimes, most commonly, what is usually seen as the plasmid acquired conjugation that happens, developing acquired resistance, which is usually seen in the escape group of organisms. So, if at all there is a question they ask you about what is the type of resistance pattern which is seen in escape group of organisms, it is the acquired type of resistance, and the way it acquires it is probably a plasmid mediated mechanism which can be via conjugation. Okay, so understanding the types transfer of resistance in acquired it can be either vertical or horizontal. Okay, vertical is usually from a parent bacterial DNA to the subsequent progeny, that is the daughter cells. It can be plasmid mediated replication. Okay, so usually transfers the plasmid into the next particular daughter cells. Coming to horizontal transmission, it can be by multiple mechanisms. Here again, the vehicle would be a plasmid. Okay, so you need to know that there is a vehicle also which happens from the first progeny to the second progeny. In horizontal transmission, it is between the same generation of bacteria. So in this, what usually happens is multiple mechanisms like transformation, transduction, and conjugation. So what do I mean by all these things? So you see, these are bacteria of probably the same generation. So there have been multiple ways that the genetic material, here you see the plasmid, based on which that is being given to the subsequent progeny of bacteria, right? So what is conjugation? You see that two bacteria here, bacteria A and B probably, connect through the structures, okay? That is the cell membrane, and then transfer the genetic material. Here, this particular genetic material is transferred. This is called as conjugation. You need to have two bacteria. You need to have a connection between the two bacteria, especially at the cell membrane, and by which directly the genetic material is transferred to the next bacteria. Okay. Remember, this is in the same generation of bacteria. The next thing is the transduction. Transduction, the vehicle changes here. Okay, we saw that transduction can happen through plasmids also, but sometimes majorly what we see is conjugation. Conjugation, transduction is usually by the bacteriophage. I'm extremely sorry for that. The vehicle we were talking about was plasmids, right? Previously in vertical transmission as well as horizontal transmission. Here in transduction, the vehicle is the bacteriophage. What is a bacteriophage? It is a modified virus that can sometimes take in some genetic material from one bacteria to the other bacteria. So it usually takes into this from one particular resistant mechanism. It can be transferred into a bacteriophage, and that goes on to another bacteria and delivers this particular mutated gene into the other bacteria, wherein this new bacteria also develops the resistance pattern. So this is transduction. So transduction is by a vehicle, that is bacteriophages. The genetic material is transferred from one bacteria to the other by bacteriophage. Coming to transformation. So sometimes after a particular time, a bacterial cell would die, right? If the bacterial cell dies, but the genetic material is still present in the milieu, that genetic material can be taken up by the bacteria in the surrounding, and they can develop certain antimicrobial resistance. So that is called as transformation. Okay, so the bacteria take up pieces of DNA directly from the environment around the cell and they develop resistance. So that is called as transformation. Conjugation, you need to have two bacteria attached to each other, direct transfer of DNA material. Transduction, you have a vehicle that is a bacteriophage, takes in the DNA from one bacteria, goes to the other bacteria, delivers the DNA material for resistance. Transformation, probably free lying resistance patterns like the DNA, which is present by probably lice bacteria, will be taken up by the surrounding bacteria and they develop resistance pattern. That is transformation. Along with this, there is another mechanism called as the integrons. They are site-specific open reading frames in the form of a mobile gene cassette. Okay, so this is also a part of transformation. So if they are present itself, they can be transferred into a particular bacteria. They also can develop resistance. Okay, so these are the ways of acquired resistance that can happen. So summarizing, acquired resistance can happen in vertical, horizontal. Vertical most commonly via plasmid transmission. Uh, Horizontal gene transmission usually follows these three or four principles, that is conjugation, transduction, and transformation. Okay. Coming to the next part of resistance, that is adaptive resistance. Phenotypically, we all saw about biofilms, persisters, etc. Right? So it can happen because of large amount of bacteria being exposed to antibiotics in the environment, that is the livestock, poultry, etc. Okay, so what usually happens is we will also invariably get exposed to these antibiotics in a sub-inhibitory concentration. Okay, because of which there will be growth factor inhibitions which happens for the particular type of bacteria, and they would develop some amount of resistance for that particular time period. Okay, one great thing about adaptive resistance is it is usually reversible because the inhibitory concentrations for such drugs would be on the lower side, but there is no cutoff totally. Sometimes if the amount of antibiotics which is present in the environment is greater, we might be exposed to multi-drug resistant uh, bacteria. This usually what happens is if it's greater concentrations are present, it can develop the mutations, because of which we will be exposed to resistance bacteria. So there will be instances, there have been instances right now, there have been multiple reports which have come in, especially with the use of colistin, etc., wherein you're seeing colistin resistant to totally colistin naive patient. Okay, in such cases, the only probable explanation that we would have is an adaptive type of resistance. Coming to the resistance patterns, which is seen in the type of bacteria, we all know there are broadly classified types of bacteria into gram positive or the gram negative. So the resistance mechanisms which are primarily seen in gram negative bacteria are decreased antibiotic entry, which can be because of porins. It can cause spitting or vomiting of antibiotics, that is the efflux. It can cause target site modifications, or it can cause degradation of the enzymes, antibiotics by enzymatic action, that is the resistome. So if there is a question asked about what are resistomes, give few examples. Probably you may have to talk about penicillinases, carbaphenemases, or any other enzymatic machinery that is present for inactivation of antibiotics. So gram negative, you have firstly, there's blockage of the entry of the antibiotic into the cell. Next, you have removal of the antibiotic by efflux, target site modifications, and inactivation by enzymes. In gram positive, majorly what is seen as the enzymatic degradation and alteration of the target site of the antibiotics. Okay, this is by and large differentiating the mechanisms between gram positive and gram negative. In gram positive, also there have been many instances wherein efflux pumps, plasmid mediated resistance have also been mentioned. By and large, this is the larger understanding. Okay, so we need to understand that gram negative bacteria are inherently stronger bacteria as compared to gram positive in view of or in consideration with defense mechanisms. Okay, so we need to understand that gram negative cell wall, it usually has an outer membrane and a plasma membrane, which gives it an extra layer of protection, which is usually not seen in the gram positive cell wall. Okay, so that is one of the reasons that we see that gram negative organisms have a better uh, antibiotic resistance, or fighting capacity as compared to gram positive organisms, wherein there might be a combination of drugs which can be still used for gram positive sepsis, and that can work. Okay, so this is in a large about what are the resistance patterns, which I've already mentioned earlier. Okay, so that can be prevention of entry, efflux, inactivation, and target site modifications. Okay, so coming to the understanding of modification of antibiotic molecule. So it can be either by chemical ways, or it can be certain enzymes which can happen. Okay, what happens in chemical modification of an antibiotic molecule? It can undergo any structural changes of the antibiotic molecule. So when I'm talking about modification by chemical methods, it is the structural change that happens to the antibiotic molecule. Okay, the molecule here means antibiotic molecule. The next part of modification is it's by the breakdown by certain bacterial enzymes. Okay, like cephalosporinases, beta lactamases, etc. So chemical degradation happens by these three processes, that is acetylation, phosphorylation, or adenylation. Okay, so majorly it happens in aminoglycoside type of antibiotics, which inhibits the protein synthesis. Okay, so addition of one of these groups by the bacteria, like an acetyl group or a phosphate group or an adenyl group, into the antibiotics makes it inactive. Okay, so bacteria is a smart, wherein it induces these type of changes in the antibiotics, thereby making it ineffective. Okay, so this is called as chemical degradation of the antibiotic. Okay, so chemical degradation is done by the bacteria. It can be under these three processes, either by acetylation, phosphorylation, or adenylation. Okay, wherein in acetylation it adds in an acetyl group, phosphorylation, as the name suggests, it puts in a phosphate group, and adenylation, it puts an adenyl group, usually making it inactive. Common drugs that you need to remember are aminoglycosides, chloramphenicol, and lincosamides. So these are the type of bacteria which usually puts in certain resistant mechanisms. You need to remember that acetylation is usually by the Enterobacteriaceae, Phosphorylation is usually seen in gram-positive bacteria. It is by the Staph aureus. Adenylation is usually seen in the gram-negative bacteria. That is the Pseudomonas type of bacteria. Okay, so this is what you need to understand. So chemical degradation is done by most of the bacteria belonging to gram-negative group. The gram-positive that you need to remember is the uh, Staph aureus type of bacteria. Okay. Enzymatic degradation, there are a lot of ways that we can classify enzymatic degradation into. By and large, they have defined it as hydrolysis, transferases, and redox enzymes. Okay, we all know beta lactamases, carbapenemases, etc. And we spoke about chemical destruction as well. So by and large, beta lactamases, we all know about Ambler's classification. In Ambler's classification, the major difference which we have, or the classification way, is by the type of the resistance molecule that has been considered. Okay, majorly the beta lactamases have been classified under serine as well as metalloproteinases. Serine metalloproteinases are class A, class C, and class B. Class B comes under metalloproteinases, that is the NDM types. Okay, usually what happens is here zinc is the metal which is present. Okay, so serine proteases are anything between penicillinases to carbapenemases. So what you can see here is the carbapenemases, they can be present in all the classes from class A to class D. Okay, whereas narrow spectrum of enzymes, that is the beta lactamases, are usually present in class A, to a certain extent probably in class D. Okay, so this is by and large understanding the beta lactamases. Okay, so why we need to understand this, I'll be speaking about this in the later slides. Okay, so the other way that you can talk about is the functional group analysis. Okay, the functional classification was given by Bush, Jacobi, Medeiros. Okay, so he classified things into group one, group two, and group three. Group one was basically AMC beta lactamases. Okay, that come under class C of the Ambler's classification. Group two consists of class A and class D. I told you basically wherever penicillinases came into picture, Bush, Jacobi, Medeiros put them into class the group 2. Group 3 usually consists of the metallo beta lactamases, that usually consists of zinc, that I told you. Majorly what you need to remember is the resistance pattern of NDM. Okay, so this is what we need to remember. Why we need to remember the classifications is probably to choose the type of antibiotics in the longer run. Okay, I will be just giving a brief update about this. Okay, coming to spice group of antibiotics. So we were talking about Bush-Medeiros classification here, and we talked about AMC beta lactamases being the functional group 1. Okay, so we all know there is something called as the spice group of organisms, and they are intrinsically resistant to chloramphenicol, ampicillin, penicillin. Okay, spice usually is an abbreviation for Serratia, Pseudomonas, Acinetobacter, Providentia, Proteus or Morganella, Citrobacter, and Enterobacter. The I there stands for the indole production or indole producers. Okay, so these bacteria usually have the intrinsic resistance to the above antibiotics. Whenever these bacteria have been exposed to probably the first or the second generation cephalosporins. Okay, so they probably develop AMC induction mechanism, that is usually chromosomal or plasmid mediated. Okay, so because of which they develops antimicrobial resistance in the long run. So you have to be very careful about these group of organisms. Whenever you have resistance which is seen for most of the organisms, if they are falling under this spice or the space group of organisms, the most common resistance pattern would be AMC induction. In that case, you can just, for understanding purposes, you can ask for history of exposure. In this day and era, most likely they would be exposed to oral cephalosporins for some or the other reason, and probably that might have been the point in which they have developed antibiotic resistance, probably by one of these mechanisms I mentioned, that is either chromosomal or plasmid mediated. So remember, spice group of organisms, AMC induction is the thing that we need to worry about. Okay, in such cases, we need to know that they will be intrinsically resistant to chloramphenicol, ampicillin, and penicillins. Okay, based on this, you need to choose your antibiotics as per your antibiogram which is available. Okay. So coming to the next part, so we spoke about permeability, degradation, and about beta lactamases in general. Now we are going to penetration problem and issues, that is the efflux pumps problem. So you know that efflux pumps are the ones which can usually vomit out the antibiotics, correct? So you have seen the diagram about the gram-negative and the gram-positive organisms. Usually efflux pumps are located as a transmembrane protein. Okay. Before that, before the efflux pump, first thing we need to consider is about entry of the antibiotic into the bacteria itself. That is the first line of defense. So what usually happens is in gram-negative bacteria, certain cytoplasmic membrane changes itself would be present. Okay, so that will make the bacteria stronger, and it would be like a protective layer preventing the antibiotic from entering into the uh, bacteria. Okay, so this penetration effect, which is being offset by the alteration in the membrane effect, gives it an additional defense mechanism. Okay, so that can happen either in the outer membrane and the periplasmic space, or the cytoplasmic membrane or the cell membrane. Okay, so this is majorly seen in the gram-negative bacteria. Okay, so because of which it can usually prevent the antibiotics totally from entering into the periplasmic space or the cytoplasm. Okay, so this is the first line of defense. Okay, so this is penetration. Okay, so firstly it prevents the entry itself, so it prevents the penetration of the antibiotic into the bacteria. Okay, the next thing that we need to understand is about porins and efflux pumps. Okay, porins, they are transmembrane proteins, which you have seen here, right? So they are present here in the outer membrane. Okay, so they usually selectively allow the movement of certain molecules. Chemicals which have a molecular weight of more than 600 Daltons usually are prevented from entering into the cell itself. Okay, mostly that is one of the reasons why gram negatives are inherently, resistant to vancomycin, that is a glycopeptide, or a daptomycin, that's a lipopeptide. Okay, usually both of these drugs have a higher molecular weight, and because of which it cannot be passed on. Okay, so that is the mechanism by which porin channels can act. Okay, porins can be two types, that is specific and non-specific. The specific type can be either based on specificity to the bacteria or the specificity to the function. Example being outer membrane protein porin, that is D. Okay, non-specific, they are common to all gram-negative bacteria. There can be OMP-A, OMP-F1, OMP-C. Okay, so these can be present in most of the gram-negative bacteria, and based on which they would develop antimicrobial resistance. Okay, so purine mutations have significant impact on the development of carbapenemase resistant Enterobacteriaceae, usually combined with other resistant mechanisms. Usually, you don't see just the purine mutation. Probably you might see a purine mutation with a target site modification or penetration modifications, etc. Okay. One important thing that we need to remember about porins is what is antibiotic trapping. Okay, what usually happens is, uh, if the porin expression is low, okay, the drug can still enter. For example, you have a gram-negative bacteria which is sensitive to carbapenems. What happens here is the carbapenems pass through the porin channel, enter into the periplasmic space. But because there is a higher expression of an other resistance pattern, in this case, probably an enzyme, that is the beta lactamase or a carbapenemase, this gets stuck between the outer membrane and the inner cytoplasmic membrane, and this gets collected in the periplasmic space. Okay, so this is called as antibiotic trapping. The antibiotic is trapped between the two layers of the bacterial cell wall, that is the outer cell wall and the inner cell membrane. Okay, so this is something which happens when the porin expression is low, whereas the antibiotic resistance of beta lactamases or carbapenemase is very high. Okay, this is one of the other ways by which antibiotic, even though sensitive, can be turned as resistant. Okay, so it can be ineffective. Okay, there will be one thing that we all notice, right? So sometimes pseudomonas, if you have seen, you get this report. Okay, you get a report telling that the patients you know, resistant to imipenem but meropenem sensitive. Can this happen? We have seen this majorly. How do we explain this? Okay, this can be explained by the porins and the channel. So usually what happens, there will be a specific porin for Pseudomonas, that is the OMPD, that is the outer membrane protein D. Okay, so it just gets transferred horizontally by horizontal gene transfer, and this sporin transfer of resistance mechanism prevents the inactivation of imipenem. Okay, so this is something that has, it is specific only to imipenem. So what happens is this specificity of imipenem makes it sensitive to meropenem, which is of the same antibiotic class, that is the carbapenem. Okay, so since it is specific porin, which is the OMPD, it can only prevent imipenem from entering, but carbapenem can pass. Sorry, meropenem can enter this. Okay, so this way of resistance pattern can be explained by the porin specificity. Okay, I'll repeat it again. Whenever you have a report of imipenem resistant, meropenem sensitive, how is it that is possible? It is usually due to specific porin channels. In this case, it is the specific porin channel to imipenem, which is seen in Pseudomonas, in which the porin channel OMPD blocks imipenem but allows meropenem to enter. Okay, because of which it is seen as imipenem resistant and meropenem sensitive. Okay, and this type of gene transfer can be given to other bacteria of the same generation by horizontal gene transfer. Okay, coming to the next part, efflux pump, production of bacterial machineries that are usually excluding compounds out of the bacterial cell wall. Okay, usually they vomit it out. Okay, there have been 5 major varieties of efflux pumps. Okay, the major facilitator superfamily. Okay, the small multidrug resistance family, the resistance nodulation cell division family, or the ATP binding acids, and the multidrugs toxic compound extrusion family. So they are different types of efflux pumps for the gram positives as well as negatives. Okay, so you need to remember that this is something that is really difficult to remember which forms for what. Just remember that whenever there is an efflux pump present, depending on the type of family, that particular type of antibiotic would be extruded or sent out of the bacterial cell, making it ineffective. Okay, so the next part of resistance pattern is the target site. It can be mutational changes of the target genes, enzymatic alterations, or target protection mechanisms. Mutational changes, like which is seen in fluoroquinolones. Okay, the gene encoding for a particular topoisomerase or DNA gyrase would be altered, making the fluoroquinolone inactive. Okay, so the next subsequent generation of the bacteria would develop this resistance pattern. Okay. Similarly, the mutational changes are also seen in linezolid, majorly in the ribosomal protein, and for rifampicin also a mutational change which is seen in the target site, usually the POB gene. Okay, which acts for the beta subunit of the RNA polymerase. Okay, so remember mutational changes, target site. The drugs usually are fluoroquinolones, linezolid, and rifampicin. So if someone asks you what is the mechanism by which resistance to fluoroquinolones or linezolid or rifampicin is seen, it is usually due to target site modification. The target site modification type is the mutational change in the enzyme, that is the enzyme machinery. It is DNA gyrase for fluoroquinolones, it is the ribosomal protein for linezolid, and it is the beta subunit of the RNA polymerase for rifampicin. Okay. Enzymatic alterations that can happen for target site antibiotics. It prevents the effective drug binding and action. I was talking to you earlier about the cephalosporins, penicillins, etc. Right, the DLN, DLNN pathway, etc. So there will be some amount of conjugation, or a Lego-like effect which happens. Okay, so that has to sit in. The antibiotic has to go in and set in a particular type of enzyme to make that machinery inactive. But that can be mutated by the bacteria, making that particular antibiotic ineffective. So this is also seen in fluoroquinolones, tetracyclines, and fusidic acid. Okay. There have been multiple mechanisms, especially seen in gram-positive organisms, wherein they bypass the target site and completely replace the target site itself. Okay, so what usually they do is, this is seen whenever you have trimethoprim resistance. Okay, the MRSA usually change the dihydrofolate reductase variants, and because of which it makes the trimethoprim resistant to MRSA at that particular type. So whole target site itself gets changed. So that is also a very smart way by the bacteria. Okay. So coming to the overview, aminoglycosides, there are multiple mechanisms: plasmid mediated, or even drug resistance by target site modification. Quinolones, you see plasmid mediated modified enzymes or the target site. Okay. Coming to beta lactams, you know beta lactamases, which are acquired types probably, and plasmid mediated, that is the horizontal, vertical transfer. Okay. Coming to polymyxins, polymyxins also have a lot of mutations that can be seen. Remember, plasmid mediated can happen in most of them except tigecycline. Okay, tigecycline, still there is no evidence for a plasmid mediation, but if things have changed, please excuse me. Okay, but when I read about it, the mechanisms by which it can do is efflux pump mechanisms and mutations in the target site. Okay. So in carbapenimases, it can be multiple. Okay, it can be by modification in the penicillin binding site, flux pump, enzymatic inactivation, and decreased penetrations, like we saw in the imipenem resistance, that is the porin channel, right? So that can be also seen in carbapenem types of resistance. So this is in just about the types of resistance which are seen in gram-positive and gram-negative bacteria. So coming to the management of MDR in ICU, I would be looking at a few drugs. Okay, the major point of this talk was to make you guys primed for what is antimicrobial resistance, and if at all a question about a certain drugs is given, how to go about. Coming to ceftazidime, if at all they ask you write a short note on ceftazidime, mention the class, antibiotic class, like it's a third generation cephalosporin. Tell what is its specificity of a certain antibiotic killing. That is usually whether it covers pseudomonals or not. Okay, usually they ask you another question. That another way of asking would be anti-pseudomonal antibiotics. Mention about its dose, mention about its mechanism of action. Okay, the dose of ceftazidime, we all know it is between 1 to 2 grams. Mechanism of action is inhibition of cell wall synthesis. That is, it binds to the penicillin binding protein. Okay, so if you know the adverse effects, please mention the adverse effects, especially for the development of C. diff diarrhea. It has been associated with neurotoxicity and renal toxicity. And by and large, if you're writing all of this, you would get some passing mark. If you want to get better marks, probably you have to include your pharmacodynamics, that is your ADME. Okay, absorption, distribution, metabolism, and elimination. In this particular thing, you can also talk about the PKPD principles. Okay, in this, most of the times it's ceftazidime, it's a cephalosporin, correct? So it acts over by time over MIC concept. Okay, so this is something that if you can add on, you would get better marks. You can probably draw in a chart as well. Okay. Coming to Zavicefta, that is ceftazidime avibactam. We all know it's a beta lactamase inhibitor, usually used for MDR organisms. Okay, it can be included even for Pseudomonas. Typical dose is 2.5 grams 8th hourly. Mechanism, again, cell wall inhibition. Avibactam is the compound which is necessary for making ceftazidime work. Okay, avibactam also has an intrinsic capability of killing bacteria. Okay, that is one thing that we need to remember. Adverse effects, like most of the things, remember C. diff pneumonia is associated, C. diff diarrhea is associated with a lot of neuroantibiotics. Okay, you can write that. Nephrotoxicity depends on the type of metabolism this drug undergoes. Okay, and this also follows the T over MIC principle. So frequent dosing is necessary. Probably you have to maintain a target site concentration of more than 60 to 70%. Okay, for which you need to give frequent dosing. Ceftaroline is another type of antibiotic that comes under the fifth generation of cephalosporins, active against MRSA. That is the most important thing about ceftaroline, correct? So we need to write these particular nuances when they ask you about a particular type of drug. To go on about each drug would be difficult. That's why I picked up few newer ones. Okay. In this particularly, you need to mention about the action of this drug in on the PBP2A, which is specific to MRSA. That is why it becomes the killing bacteria, antibiotic for MRSA organisms. So mention the drug effects. In this, you need to remember it causes effect on the bone marrow, probably can cause neutropenia, thrombocytopenia, and in extreme cases can also be associated with hemolytic anemia. I am rushing a little because there's another talk that I need to cover. Okay, eravacycline. We all know this has been used for a lot of resistant strains like carbapenemase resistant Enterobacteriaceae and probably even Acinetobacter. But there have been recent evidences where it can actually show decreased effect and probably increase the mortality. I'll be discussing about the crab in the next few slides. Okay, it is a bacteriostatic drug. Remember this particular point about eravacycline. Okay, coming to Aztreonam, it's a monobactam antibiotics usually used in MDR organisms whenever you have NDM positivity along with probably OXA48 or anything associated with this, carbapenemase resistant Enterobacteriaceae. So usually it inhibits the penicillin binding protein 3. Okay, that is, it further prevents the bacterial cell wall synthesis. Sulbactam, usually this drug is used for in combination, sometimes for the carbapenemase resistant Acinetobacter baumannii, correct? So that is one of the things that have been mentioned off lately, the dose being up to 3 grams every 6 to 8 hours. Okay, it inhibits the beta lactamase activity by certain bacteria, and then it makes the bacteria susceptible to the other compound. Probably you can use carbapenem or probably minocycline, etc., by which the bacterial lysis can be achieved. Okay, so cefiderocol is a siderophore cephalosporin. It is a cephalosporin. It doesn't come under any of the classifications as mentioned, like up to the fifth generation. It usually gets collected in the periplasmic space. Okay, so this is one of the game-changing antibiotics which is present in the current armamentarium. Probably this use has to be thought about before we, consider the use of cefiderocol. It has to be under the antimicrobial stewardship program before anyone can use it inadvertently. The dose is 2 grams TID. Mechanism of action is usually it's transported into the periplasmic space in which it binds to the penicillin binding protein and inhibits the peptidoglycan synthesis. Okay, it can also cause passive diffusion through porin channels. The adverse reaction which have been seen is pancytopenia and drug-induced liver injury. Okay, daptomycin, we all know it's a cyclic lipopeptide, which is usually used for VRA and MRSA. The dose being 4 to 6 milligrams per kg. The mechanism of action is rapid depolarization, causing the calcium-dependent manner. It causes bacterial cell membrane to get inactivated. Okay, that depends mainly on the calcium. Because of the membrane depolarization, it causes disruption of protein synthesis, which includes both the DNA and RNA synthesis. Okay, it is bactericidal but not effective in treating lung infection because it gets rapidly inactivated by the lung surfactant. Okay, so remember, daptomycin is not a drug of choice for any pneumonias. Okay, adverse effects, it can cause severe rhabdomyolysis and myopathy. Coming to management of MDR organisms, this is something which is from the latest 2024 IDSA guidelines. Okay, I just wanted to include this majorly in this talk. Okay, how do you treat Acinetobacter crab organisms? What is the current guidelines? The preferred drug they have told is any sulbactam containing agent. Sulbactam durlobactam, if it is available, can be used, or else you can use imipenem cilastatin along with a sulbactam combination or a meropenem sulbactam combination. High dose minocycline over tigecycline has reported better outcomes with crab organisms. Eravacycline, which was shown to have sensitivity for crab, has been downgraded. Okay, there have been multiple trials which have been done, which has shown increased mortality with the use of eravacycline, for which currently the IDSA does not recommend the use of eravacycline for crab organisms. Okay, cefiderocol usually is considered as a last resort drug. Always use it as a combination therapy. Okay. Coming to carbapenemase resistant organisms, IDSA usually divides it into these headings like uncomplicated cystitis, pyelonephritis, urinary infection, okay, or else the resistance pattern in CRE, that is NDM positive or NDM plus OXA48, okay. So usually uncomplicated cystitis, it's a usual go away by whatever antibiotics that you have based on your local antimicrobial. But if you come to the resistance patterns, okay, that is your KPC, NDM, and OXA48. If you have a KPC type of organism, it's probably Zavicefta or Meropenem vaborbactam or Imipenem cilastatin or Relebactam can be the drug of choice. Coming to NDM, I told you it is a combination of Zavicefta with Aztreonam. Whenever you have OXA48 positive, Zavicefta alone would be sufficient. There is no need to add the monobactam, that is Aztreonam. But if you have an NDM positive, that is your metalloproteinase, metallobeta lactamase, correct? If that is present, you need to make a combination of Zavicefta plus Aztreonam. Okay. Usually, if you have only NDM positive, Avibactam Aztreonam combination would be sufficient, but the availability of Avibactam Aztreonam is quite rare. So that is the reason we have to add a combination of ceftazidime Avibactam plus Aztreonam. In both these cases where NDM and OXA48 are present, the alternative drug which is present is cefidericol. That is your Siderophore cephalosporin. Remember, whenever you are considering tigecycline or avacycline, majorly it acts on lung soft tissue. Okay. Never consider the use of avacycline or tigecycline for bloodstream infection or urinary infection. Okay. So any solid organ, use tetracyclines. Okay. But if it is a septicemia or kind of an infection or urinary infection, probably these two drugs are inefficient. Okay. Majorly because it gets rapidly eliminated from these two sites. Role of polymyxin in CRE. Colistin is an excellent choice for urosepsis, but no role for combination antibiotics for carbapenemase resistance organism. Okay. So this is what has been said. Again, use of colistin alone or else with a combination has been a debate since long. Okay, depends on the MIC, depends on the antimicrobial pattern which is present. It's always better to use combination. Okay, but the combination when I'm mentioning it is about colistin with a meropenem, colistin with a carbapenem. Okay, that is what we are telling about. It's not for other combinations. Other combination, what we are trying to tell here is probably a tetracycline, like I mentioned earlier, or a cephalosporin. Okay. Coming to MDR pseudomonas, coming to IDSA 2024 guidelines, they usually say that uncomplicated cystitis or pyelonephritis, it's one of these drugs. That is your combination of usually your BLBLI or carbapenem with a BLI. Okay, so that is one thing. But if you have a resistant strain like NDM, you have to go ahead with use of Zavicefta with Aztreonam and cefidericol. It is similar to what is seen in CRAB, okay, or CRE. What usually is said is a high dose infusion therapy of 3 hours is better. Okay, so usually cefepime, etc. When you're using, probably a longer dose would be better. Okay, there are multiple newer drugs like cefepime, enmetazobactam, etc. coming in. So whenever you're talking about such cephalosporins, they depend on time dependent killing, time over MIC. So giving an infusion therapy would be better. Okay. Stenotrophomonas, always remember here in these kind of drugs, your carbapenems are ineffective. So meropenem does not act on stenotrophomonas. The drug of choice would be trimethoprim or fluoroquinolone. Cefidericol and minocycline have also been effective against these bacteria. The other thing would be a combination of Zavicefta with Aztreonam. But in this case, always save in your Zavicefta Aztreonam. Okay. ESBLs, we know that the drug of choice would be carbapenems. Okay, there have been newer drugs which are coming into picture, that is ceftolozane, tazobactam, etc. They can be tried under such drugs. Remember your Merino trial for such things. Merino trial did give a non-inferiority, picture for Piptaz compared to meropenem. So that is something that I want you guys to still remember. Okay, thank you. I know I've exceeded my time, so without first making wasting some more time, I'll just go into the next topic. Okay, so SGLT2 inhibitors, I think so. People who are exposed to a large number of cardiac patients, you might have seen your, cardiologist prescribing these drugs. Along with this, you might have also seen these drugs with patients with diabetes, especially type 2. I'll be dealing it under these headings. that is basics, mechanism, and role in critical care with evidence. SGLT2 inhibitors act on the kidneys, that is the proximal convoluted tubule, especially the S1 segment. Okay, so what does it do? We all know that it acts on the proximal convoluted tubule of the nephron. Usually, the renal threshold for glucose is 180, right? And what do I mean by that? Until the threshold is reaching 180 milligrams per deciliter, the glucose will be still taken in and it will not be excreted. But what these SGLT2 receptor inhibitors do is they filter out 90% of the glucose at the proximal convoluted tubule. Okay, so this thereby prevents glucose reabsorption and results in glycosuria. What you need to understand is the renal threshold for glucose is lowered by SGLT2 inhibitors. Next important thing, because glucose is excreted, sodium reabsorption is also inhibited. Okay, so what usually happens is it inhibits the sodium reabsorption, thereby increasing the overall sodium load because it causes natriuresis as well. Okay, so it causes glycosuria and natriuresis. Okay, because it does these two things, it has an effect on the energy expenditure. Because there is a loss of glucose in the urine, it can cause a calorie deficit, because of which it induces osmotic diuresis. Okay, and because of osmotic diuresis, what happens is the effective circulating volume is reduced, causing a drop in blood pressure. Okay, this is not a drop in blood pressure causing hypotension, but overall the preload is reduced in such patients. Okay, what are the physiological effects? In the glucose metabolism, it causes reduced blood glucose levels. It has caused decreased HbA1c levels. It improved the insulin sensitivity. Coming to the metabolic effects, it causes weight loss, reduced visceral adiposity, improved lipid profile. The cardiovascular impact, it causes reduced cardiovascular events by decreasing preload, better utilization of byproducts or the substrates. Okay, I'll be mentioning about them in the later slides. And improved heart failure outcomes. And it also caused decrease in the occurrence of atherogenic events. That is probably a long-standing nephropathy, retinopathy, etc. Renal protection has also been attributed to the use of SGLT2 inhibitors, that is reduced albuminuria. It preserves the glomerular filtration and slows the development of chronic kidney disease in diabetics and non-diabetics alike, both. Okay. So pharmacokinetic principles, it is usually oral administration. It has a rapid absorption. It is usually metabolized in the hepatic, it is in the liver, but it is a non-cytochrome P450 type of a metabolism. So there is no inducing action which has been attributed to SGLT2 inhibitors. The elimination is by the kidney, and the half-life is roughly around 12 to 24 hours, depending on the type of SGLT2 inhibitors. The inhibitors are dapagliflozin, empagliflozin, canagliflozin, and tugliflozin. So there have been two generations. The common ones that have been extensively studied are in the first generation, that is the dapagliflozin and the empagliflozin. The second generation, it inhibits both SGLT1 and 2, that is your ertugliflozin and the sotagliflozin. The dosage adjustments usually has to be considered in severe kidney diseases, especially when the GFR drops below 60. Okay, so most commonly what is used is dapagliflozin and empagliflozin. Once daily dose can be sufficient, usually starts with 5 to 10 mg. Okay, that is what we can start off with. For empagliflozin, it's 10 mg, we can go up to 25 mg. Dapagliflozin starts with 5 mg and we can go up to 10 mg. Canagliflozin is routinely not used, but in India, what is commonly used are these two, that is your DAPA and empagliflozin. Potential adverse effects which have been seen are the common ones are mycotic infections, probably urinary. It has been also associated with Fournier's gangrene. Urosepsis, it's a strict contraindication as well. If the patient has this, we cannot initiate them. Volume depletion, as I've already mentioned, it causes natriuresis and glycosuria, because of which there will be effective drop in circulating blood volume. So very rarely it has been associated with hypotension. So rarely there have been case reports of euglycemic diabetic ketoacidosis, acute kidney injury, and bone fracture. The American Diabetic Association has given a clean chit to SGLT2 inhibitors. It said that the benefits outweigh the risk with the use of SGLT2 inhibitors. So euglycemic ketoacidosis should not be one of the things that we keep in mind and prevent the use of SGLT2 inhibitors. Okay, so this is the risk and benefits that have been seen with SGLT2 inhibitors. A role in critical care. Okay, we all know the hemodynamic effects is because of the natriuresis and the diuresis. By causing glycosuria or uricosiuria, it decreases the insulin resistance, decreases body weight, increases in ketosis, which is actually a substrate for cardiac metabolism. And these two things combined, that is the hemodynamic effects and the metabolic effects, reduces the risk of heart failure. Okay, so usually it's a bidirectional thing which happens. It is both renoprotective and cardioprotective. Okay. In heart failure, what usually happens is we know that the effective circulating volume is reduced. It also, inhibits the sympathetic nervous system activation, wherein the cardiac afterload is reduced. Okay, and the arterial stiffness, which is seen, that is also reduced. Because of the initiation of SGLT2 inhibitors, the substrate utilization is shifted from glucose to ketones. Okay, ketosis would be set in these patients, and this ketones is a more efficient fuel for the cardiac myocytes, thereby increasing the efficiency of the utilization of substrate and decreasing the demand for oxygen. And this is one of the reasons wherein there have been mortality benefits associated with the use of SGLT2 inhibitor. Okay. It also has been attributed to have anti-inflammatory and anti-fibrotic effects. And because of all of this, it has an overall reduction in hospitalization, mortality, and prevention of disease progression. Okay. So initiation criteria depends on prevention criteria, active management, or in cases of advanced heart failure. In whenever you have a patient with diabetes and IHD, probably it would be wise to start this patient earlier on SGLT2 inhibitors like dapagliflozin, because long term the development of heart failure in such patients has been shown to have reduced. So what happens if the patient is already a case of heart failure? It has been shown that multiple trials with the patient having an EF of less than 40% with a symptomatic heart failure, the use of SGLT2 inhibitors have prevented further worsening and have reduced the length of hospitalization and development of other organ failures. Okay. Coming to comorbidity assessment and risk stratification, it has been used in most of the patients, be it obese patients, patients with CKD, patients with renal dysfunction or metabolic derangements, even in elderly age group or patients with poor reserve. There have been good outcomes with the use of SGLT2 inhibitor. Okay, so whenever you have an EGFR more than 30 with a moderate renal impairment, you can keep a watch on these patients. No need to stop it. But if it goes to end-stage renal disease, probably you might have to stop the use of dapagliflozin or empagliflozin. Okay, it can be used in both diabetics and non-diabetics. Okay, so it prevents further worsening of the cardiovascular events. Okay, so there have been multiple trials which have been shown. That is the DAPA trial and the Emperor trial. Okay, in the DAPA trial, heart failure trial was done in patients with reduced ejection fraction. The Emperor and Deliver trial were done in preserved ejection fraction. Both of this showed significant outcomes. Okay, so remember that it's a class 1 recommendation, or sorry, for the use of SGLT2 inhibitors in patients who have been diagnosed with heart failure. Okay, current recommendation is one of the things that has to be used in the first line therapy along with your other drugs. Okay, your 4 pillars of heart failure, that is your beta blockers, mineralocorticoid antagonists, okay, your ARNIs, which will be discussed later on, and diuretics. Mechanism in CKD, you know that it restores tubuloglomerular feedback. Along with that, it reduces the glucose threshold on the kidney, wherein it prevents the oxidative stress which is present on the kidney. And because of the metabolic effects, that is improved glycemic control, the small vessel damage, which usually leads to worsening of the kidney function, that will be prevented by the use of SGLT2 inhibitors. Okay, multiple trials like the DAPA CKD trial and the Credence trial has shown benefits with the use of SGLT2 inhibitors even in the patients with CKD. Okay, metabolic pathways, it I have already mentioned, insulin sensitivity is increased, glucotoxicity would be decreased, ketogenesis is decreased because ketones get utilized by the cardiac myocytes. Okay, There will be potential risk of DKA, but there have been a subset of patients wherein it can also reduce the incidence of diabetic ketoacidosis if the hydration and adherence to other OHAs or insulin is proper. Okay. We all need to know whenever there's a patient on ESRD, stop SGLT2 inhibitors. Always look for development of UTIs in these patients. If there is UTI, please discontinue. There have been case reports of Fournier's gangrene in such patients. Probably we have to stop this, treat the infection. Thereby, after this, probably need to consider whether to continue or not. These subset of patients, probably it would be counterintuitive to continue SGLT2 inhibitor. Okay. So heart failure, AKI prevention, sepsis, hyperglycemia management are the core areas in critical care. Okay. Always be aware of volume depletion. In case of severe sepsis with septic shock, probably don't initiate SGLT2 inhibitors at that time. Once the patient is stable, probably before discharge, you can think about it. DKA, if the patient has developed DKA, stop dapagliflozin. Instant renal disease, developing the need for renal replacement therapy, stop it. Okay. So this is basically from this journal. There are multiple trials and multiple review articles that have been present. Okay.